The first abstract is EV202. This is a phase 2 multi-cohort study where I would be discussing breast cohorts where there are two cohorts, hormone receptor positive, HER2 negative and triple negative breast cancer. So these are locally advanced or metastatic breast cancer. Prior taxanes or anthracyclines are taken by the patients, and most of them are more than one line of cytotoxic regimen. For hormone receptor positive subset, CDK4/6 inhibitor or some kind of endocrine therapy is mandated. For TNBC, prior PDL1 L1 inhibitor based on PDL1 expression was needed. EV was given 1.25 milligram per kg IV day 1, 8, 15 every 28-day cycle. And investigator assessed confirmed overall response as per RECIST was primary endpoint. So they had a pre-specified overall response threshold for hormone receptor positive subset. They needed 12 patients out of 40 to respond. But the response was seen in 7 patients. The overall response rate was 15.6%. In TNBC subset, they needed 10 patients to respond out of 40, but 8 patients responded. So overall response rate was 19%. Both TNBC and hormone receptor positive patient had a lot of Nectin-4 expression, but response was not determined based on Nectin-4 expression in both the subset. Progression-free survival median PFS was 5.39 months in hormone receptor positive subset, while it was 3.52 months in triple negative breast cancer subset. This drug is not extremely easy to handle because you have almost 45% of grade 3 or more toxicity in hormone receptor positive subset and around 30% of grade 3 or more toxicity in triple negative breast cancer subsets. There were interruptions or dose reductions in range of 35 to 45%. So especially the skin toxicity is something which we need to look at when we are giving enfortumab vedotin. So the author concluded that because the pre-specified threshold were not reached, so in spite of activity, these thresholds are not reached, and they would probably have more trials or they will explore more how to bring AV in practice. So my conclusion is early signals are not strong for EV. Overall response rate is less than the pre-specified threshold. There is substantial toxicity. Cost would be very important for us when this drug is available. And we have better data with other ADCs, and probably they would be preferred at this point of time. And we probably will have to learn how to sequence them. As of now, EV as a single agent is not useful for routine clinical practice. The second abstract which I'm supposed to present is Olympia, pre-specified analysis of IDFS, DDFS and overall survival 10 years from first patient in. Olympia trial of adjuvant olaparib in germline BRCA1/2 mutated breast cancer. So we all are aware of the trial schema. Patients were germline BRCA1 or 2 positive, HER2 negative patients. So it can be hormone receptor positive or TNBC. Stage 2-3 breast cancer patients who lack PET-CR to NACT. So in neoadjuvant group for TNBC, you have non-PET-CR patients, and for hormone receptor positive, you have non-PET-CR patient, and we have to look at CPS plus EG score, which had to be more than equal to 3. In adjuvant group, TNBC, anything more than 2 centimeter or node positive is eligible for olaparib, and for ERPR positive, N2 or higher disease would be needed. So patients were randomized 1:1 to olaparib 300 milligram twice daily for 1 year versus placebo, and primary endpoint was invasive disease-free survival. So these are the IDFS event. The median follow-up is around 6 years, and this is 10 years after the first patient was in. So currently number of IDFS event around 19.3% in olaparib and 28.2% in placebo arm. We can see that there is decrease in distant recurrence, 11.5% versus 16.3%. There is decrease in regional recurrence, 1.2% versus 2.4%. Decrease in contralateral invasive breast cancer, 2.8 versus 3.9%. And second primary non-breast malignancies, 2.2% versus 4%. This is invasive disease-free survival in intention to treat population. So at 6 year, IDFS rate difference is 9.4%, and stratified hazard ratio is 0.65, confidence interval of 0.53 to 0.78, not crossing unity. IDFS by hormone receptor status. So in triple negative, at median follow-up of 6.3 years, the stratified hazard ratio is 0.65, not crossing unity. The confidence interval is not crossing unity. While in ERPR positive patients, at median follow-up of 5.7 years, hazard ratio is 0.68, but confidence interval do cross unity. We can see that number of patients in extreme right in ERPR positive patients are really low, number of patients at risk. So probably we are seeing that convergence. So in ERPR positive, we will require more events probably to have that confidence interval within 1. For overall survival in intention to treat population, at 6 year interval, median follow-up difference was 4.4%, and the stratified hazard ratio is 0.72, and it is not crossing unity. 0.56 to 0.93 is the confidence. This is subgroup analysis. We can see that most of the subgroups are benefiting. The line of unity is crossed by patients who are hormone receptor positive, HER2 negative. Again, the number of events are really low. That is probably the reason why this is the case. Important thing is there is decrease in new primary malignancy. In olaparib, it is 4.9% versus 7.5% in placebo, and the majority of this is due to breast malignancy, 2.9% versus 4%. So my conclusion would be at 6 years of median follow-up, you have an invasive disease-free survival, distant disease-free survival, and overall survival in intention to treat population. And this is a very important addition to our armamentarium for treating this kind of patients. As such, we were using this drug, but a longer follow-up helps us to make the decision easy. In hormone receptor positive subset, there will always be discussion of using olaparib versus CDK4/6 inhibitor, but germline BRCA positive being a biomarker driven treatment, olaparib would be probably a preferred drug in hormone receptor positive subset also. In TNBC subset, olaparib versus capecitabine, germline BRCA mutated would generally receive olaparib, and rest of the patients who have not received PET-CR post-neoadjuvant would receive capecitabine. Whether we can give these drugs in combination with pembrolizumab in adjuvant setting is something which we have to consider. And something which I was not aware of was there are fewer new primary malignancies in olaparib arm, largely driven by breast cancer malignancies, and there was no evidence of increased risk of MDS or AML even after 6 years of median follow-up, which we always are worried of when we are giving PARP inhibitors. Thank you.